Thank you, David. I'm very much reassured this morning because down in my little corner of England, all my colleagues pick up laparoscopes and put in bids for robots, and I still haven't yet had the keys for the robot handed over. And so to see Tim's slides and to hear David talk about the role of open surgery makes me feel as if I still have a job for the next few years, so thank you. It's a little bit like an MDT, isn't it? Because we've got a radiologist and we've got some pathologists and we've got a lot of urologists. And surgery for lymph nodes and recurrent disease is two separate topics, but it's a topic in our MDT which occupies quite a lot of time. We churn through a lot of renal tumours, and then we always stall when we see recurrent disease and when we see lymph nodes. Just to turn our attention firstly to the lymph nodes, I think there's one vital question. Let's go right down. Let's go right to the core of this, really. Does a lymphadenectomy improve the patient's survival? And there are a number of patient groups. If we start with the N0 patients, N0 on preoperative CT, then what I tend to be told in our MDT is that the EORTC in 92 told us that there's no survival advantage in performing a lymphadenectomy. It's a large study, 700-odd patients, T1 to 3, randomized radical nephrectomy to radical nephrectomy and lymphadenectomy, no survival advantage. But I think quite a few of us in the audience talking to you, think that this may have been an underpowered study. It's a long time ago, and was the data really mature enough to draw that conclusion? If you actually go back and reanalyze those patients, 3% of them actually had micrometastases in clinically normal nodes, and actually 14% of them had recurrent disease in their lymph nodes later on. So you could argue that that data needs to be thoroughly reanalyzed, and that study needs to be reevaluated. So should we do a lymphadenectomy for everyone with N0 disease? Well, I don't think we can currently justify that. These are my results, and warts and all really. For a full-on lymphadenectomy in renal cell cancer, you are making this a much more difficult operation. There's more blood loss. It takes longer. And you will get lymphoceles, either clinically or on CT scanning, or on prolonged drainage from your drain. It's a tricky operation. It's not a straightforward operation. It's not necessarily an operation which does lend itself to a lumbar approach, or a laparoscopic approach, or dare I say even a robotic approach. I spent some time at the Mayo Clinic, and I think the one lesson I learned at the Mayo Clinic is data, data, data. They have an amazing data collection system. They have a 6-story building, with hundreds of people collecting data. And what it does is it means that every patient through that clinic gets logged. Every aspect of their care is logged, right from the colour of their socks right through to the genetics of their tumour. And that means they can plug in questions at random and get great guidelines and protocols and churn out papers. So whenever I think there's a clinical dilemma, I always go back to the Mayo Clinic and ask them the question. In actual fact, they have a nice guideline. Not a nice guideline, a good guideline. Irrespective of the preoperative CT scan, what they do is they perform a lymphadenectomy if the tumour's big, if there's obvious necrosis on a CT scan, if the patient's anemic, or if there has been frank hematuria. That's quite a lot of patients, because if you go out there and look at the posters, the interim renal cancer audit, Tim, I think shows 30% of patients will have frank hematuria, another 1% will have anemia. So you're talking about quite a lot of patients. And what they find is if you've got 2 of these factors, then you've got a 76% accuracy at predicting lymph node positivity. So it's quite a powerful guideline. And that's the sort of guideline that I use to argue for quite aggressive lymphadenectomy in our MDT. Now, what about the next set of patients? Those who've obviously got lymph nodes. So these are patients who've got locally advanced disease. They've got metastatic disease, in a sense, local lymphadenopathy. Is it worthwhile performing a lymphadenectomy? Well, yes, absolutely it is. And if you go and look at several large series, I've just plucked 3 here, which give you a wide range of survival advantage, but the very worst gives you a 5-month survival advantage for an aggressive lymphadenectomy. And 20 months is a long time if you're dying of cancer. And then if you look right up to date at the MD Anderson experience from 2011 published, that's almost a 40% 5-year cancer-specific survival for aggressive resection of node-positive disease. So it's impossible not to justify aggressive lymphadenectomy for N1 disease. And then finally, lymph nodes, what if you've got metastatic disease? We've just heard from David that the rationale for cytoreductive radical nephrectomy. So should we go the whole hog and take out all of the lymph nodes? It probably doesn't alter survival over and above the cytoreductive radical nephrectomy. In the 2001 study from the NCI showed no advantage. But that's a long time ago. That's 10 years ago. And we know that there are some tantalizing small studies out there showing us, 5-month survival advantage from the UCLA study for patients undergoing lymph node debulking at the same time as their radical nephrectomy with metastatic disease prior to interleukin. And of course, where are the results of the TKI trial? It's the same argument, really. We've got to plug these patients into trials so that we know the role of targeted therapies. Tim's shown some fantastic slides. I love, the second best thing to being a surgeon after doing the operation is, I think, watching other people do operations. I never tire of watching people do operations. And I put this slide up not really to tell you, how to do the operation, because I'm sure you're all aware that, for a right-sided tumor, you're looking at a lymph node dissection up to the crus of the diaphragm, down to the aortic bifurcation, and most importantly, across the midline, so across here to the intercaval groove. Some people have argued on sort of classical anatomical studies that we should actually be going across to the contralateral renal vein. I do that for an RPLND, that's my routine approach. But of course here you've already removed one kidney, and the last thing you want to do is start to damage the healthy contralateral kidney. So I do draw the line at the aortocaval groove. For the other side, for the left-sided tumours, slightly less aggressive surgery up to the crust of the diaphragm, and some people down to the aortic bifurcation. I tend to, if they're over 40, and if they're over 40 and a smoker, as is not uncommon finding, I tend to stop my dissection here at the inferior mesenteric artery, having had one patient who I tied the IMA in a 60-year-old smoker who then had ischemia of the left-sided colon. So I tend to limit my dissection there. But I show this slide not to tell you how to do the operation, having told you how to do the operation, but mainly just to remind myself about one of the biggest issues we've got here, which is training. And again, down in Bristol, we live in our own little world down there, but it is an issue, is that all of our trainees are absolutely desperate to learn robotic prostatectomy. They're absolutely desperate to be dab hands at laparoscopy. But I don't find that many of them are desperate to learn how to do this type of surgery. Maybe it's just our experience. This is probably Tim you'd agree. It's often vascular surgery that you're doing. It's often general surgery. It's often dealing with a bit of colon that you've had to remove, etc., etc. So there are major issues on training. Just a couple of slides to bring home the point that right-sided tumours often do cross the midline. The lymphadenopathy crosses the midline. There are the nodes. They're in the aortocaval groove, and they were positive. Sometimes you get these massive things. That's a renal cell cancer. The lymph node deposit is bigger than the primary tumour. The IVC we didn't see preoperatively, but it's up there in actual fact, bowstringed around. It's making the point, again, that a right-sided tumour, the lymph nodes have crossed the midline. That's actually in the aortocaval groove. So it's just a quick show of hands then to see if anyone was listening. Radical nephrectomy would be a standard treatment. Would anyone like to perform a radical lymphadenectomy at the same time for this patient? Hands up for a lymphadenectomy. A few people. Yeah, it's a difficult one, and it's a controversial one, isn't it? You've got a tumour which is sort of just on the border of 10 centimetres. You've got some shotty nodes, but they're below clinical significance as RECE criteria. You've actually got a patient there who did have preoperative macroscopic hematuria and did indeed have a radical lymphadenectomy and did have positive nodes. So it's just proving the point that you can't completely live to the guideline. So moving on now, just shifting completely to look at recurrent disease, separate issue. So does resection of recurrent disease actually benefit a patient? That's the key question, isn't it, really? Is it a common finding? I think it's common because I get to see a lot from the southwest. You know, I get to see them from down in Penzance, referred to Bristol, and from Gloucester and all sorts of places. So I think it's common, but in actual fact, it's not that common. Local recurrence, maybe 2%, following a radical nephrectomy with curative intent. And what actually is local recurrence? Well, I think it's recurrence in the adrenal gland, in lymph nodes, or in the soft tissue renal bed. Is it local recurrence or is it metastatic progression? I think it's local recurrence. I think that what's happened here is that for some reason the surgeons decided not to remove the adrenal or not to do the lymphadenectomy, or a tumour cell has left the primary tumour at the time of surgery and deposited itself in the renal bed. So I think it's entirely justifiable to excise local recurrence. It's the same disease. It's the primary disease after all. Is it worth doing? It is definitely worth doing. Aggressive surgical management improves survival. And you can pluck studies from all over the place. I've given you two here, which admittedly have got very good results. 40% 3-year cancer-specific survival for aggressive resection of local recurrence. A 51% 5-year survival, that one is the second one, for aggressive surgical resection. It is worthwhile doing. Is it better than drugs? Well, it seems to be. A lovely study. I love simple studies. This one's a really simple study. It's 30 patients, 3 arms, 10 in each. And you've got local recurrence, you've got observation, surgery and drugs, and it's the surgery that wins. What factors predict for the best outcome in local recurrence? Well, they're pretty obvious, really. Small recurrence, less than 5 centimetres. If it's not turning itself into some horrible sarcoma, if your resection margin is negative and you've got some normal bloods, then you've probably got a good chance of giving an excellent survival. 111 months, 10-year survival if you haven't, you know, if you've ticked all of those boxes. And if you've got one or more of those factors, the survival drops off dramatically to less than a year. So what is the role of drugs? It's a common theme during these 2 days of meetings. What actually is the role of the drugs? Well, there's a very tantalizing study here which we can finish on from 2011, and it's targeted drug therapy prior to aggressive surgical resection of local recurrence. So this is neoadjuvant therapy for local recurrence. And what do you find? It's a small study, not a vast number of patients, but you get a less positive margin rate and the tumour size is often reduced. So this, I think, will become, I'm not saying it has to be, but I predict it will become the sort of standard of care. Just to look at a few pictures to finish then. So I often find the local recurrence on a clip for some reason. I'm doing some studies with the pathology department in Bristol. We're actually looking at what happens when you put a clip on, obviously usually an artery or a vessel, and what happens. Does it trap tumour cells there as opposed to a suture, or is there a better form of energy? Should we be using a high energy a heat source to cut vessels rather than put clips on? Because I often find local recurrences on clips. Here's another example. This for me just sums it up. This must be a spilt tumour cell at the time of surgery. A nice little isolated recurrence sitting on the muscle, and just to prove that we can take it out. Here's a right-sided recurrence. This is on the renal vein. Again, another popular site of recurrence. So still some clips there, you'll notice. Quite a bulky one. I was worried about removing this because usual question, where's the IVC? And so this patient has a TKI, has suitant therapy, and it shrinks. It's now less than 5 centimetres, and the resection margin is negative. So it's just following on from that 2011 study showing neoadjuvant therapy with suitant. So I think I'm very, very passionate about this, that lymphadenectomy and surgical resection of local recurrence is worthwhile for the patient. and we shouldn't really be having MDT discussions to that effect. It should actually be, we should be reversing those questions and saying which patients shouldn't be having a radical lymphadenectomy. And just to be controversial to the oncologists, because I thought there'd be quite a few of them here today, this morning session, despite advances, the only curative treatment for locally advanced or recurrent renal cell cancer is surgery.